Well, good afternoon, everyone. Thank you for coming along, and all those who haven't come yet, we're really, really annoyed, so you just have to hurry in. My name is John Bell. Obviously, of the two, I'm the John Bell one, and I'm with my co-presenter, Catherine Duggan, who I'm not going to introduce because she's introduced herself all over this city, really, for the last few days, as CEO of FIP. Now, we're going to talk about pain management, as you can see there, specifically acute pain management. So I'm going to provide the pain and Catherine's going to provide the relief. That's the way we're going to work this. We're looking at optimal care, reducing risks of harm in pharmacy. We reckon if we can manage acute pain, we don't even have to go to chronic pain. That's one of the major issues here. So it's accredited. You'll get 1,000 CPD points if you pay close attention. Otherwise, just one. One might be enough for everybody, really. Now, over the last few years, there's been lots of changes in, well, I suppose the pain landscape, hasn't there, in many countries, including my own, which, if you haven't already guessed, is Australia. I think that's where we are today. Insofar as changes to codeine and paracetamol specifically, I guess codeine, paracetamol and NSAIDs are the three groups of products we use to treat acute pain. Codeine has fallen into disrepute, as have most of the opioids, of course, where they're great, but not used appropriately, they're not so good at all. So in Australia, you'll see codeine is really no longer available without prescription. Opioid reforms have taken place even with prescription products as well. In terms of paracetamol, modified release paracetamol was scheduled to non-self-selection. And there's been, well, there will be further changes to paracetamol accessibility in a couple of years' time. In Britain, you'll see there's some reforms there in terms of access of codeine, patient risk warnings, pack size restrictions in terms of paracetamol. And I was going to say elsewhere in Europe, and I'm not too sure whether Britain knows whether they're in Europe or not these days. They're thereabouts anyway. But in Europe, age restrictions to do with codeine, specifically in Germany, related to pack size restrictions and modified release suspension changes as well. So why opioid changes? Well, I guess it's fairly obvious in a way. There have been enormous increases in deaths. In that 9-year period, 10 years I guess, there's been a doubling of the number of codeine-related deaths. And of those, 40% are considered to be those self-selected. So codeine that comes from our pharmacies. And the harms of codeine, well, in non-prescription doses, it's never been considered all that great anyway, has it? I mean, it causes more harm than good, and of course we know with all opioids, there's tolerance develops, there's dependence, adverse effects of which we know there are many, and this hyperalgesia, which means that codeine and the other opioids tend to make those receptors, the nociceptors, more sensitive to pain stimuli. So it's not a great medication, really. With regard to paracetamol, well, we know the modified release formulations have some benefits. They can be taken in slightly, I guess, fewer doses, or less frequent, I should say. But in overdose, the modified release paracetamol is a complex kind of molecule to treat. It causes usually liver toxicity that's hard to overcome. So I should stress that in appropriate recommended doses, non-prescription doses, paracetamol is quite safe and effective, or effective in many pain conditions, but in overdose it's very problematic. To you, Catherine, you can tell us more about what's happening elsewhere with all these pretty flags.
Thank you so much, John. Welcome, everybody. As you mentioned, I'm Catherine in this double act. You can see there's a lot of data underpinning this slide around where limitations in pack size have been implemented. It's very interesting to think about these medicines that are so commonly available and the level of toxicity associated with them. It makes you think, if they were being licensed today, what would we really be making available? So the introduction of a pack size limit really was about the idea that you can cause yourself huge toxicity with paracetamol at very low doses. The study in the UK found a 22% reduction in suicide deaths in the 3 years when the pack sizes were restricted. There was a 30% reduction in liver toxicity complications, which also has an impact on the acute healthcare setting. 30% reduction in large overdoses, and then of course we move into the salicylates, which is a 39% reduction there. Ibuprofen overdoses actually increased after the legislation change. Obviously people were looking for pain relief elsewhere or looking for other medicines to harm themselves, but that had little or no effect on deaths. The big issue with this slide is there's much smaller margin of error when dosing paracetamol, which contributes to its concerns. And of course, then in a pharmacy setting, or if someone is buying medicines over the counter from different places, they can easily double up or treble up on the paracetamol they are taking. This is reflected in the fatality data. In Victoria, not my country, but understanding that Victoria is very, I suppose it's a good example of the evidence that is needed elsewhere for this. An average of 36 paracetamol overdose-related deaths were annually reported, compared to 4 ibuprofen overdose-related deaths. There were no reports for aspirin. The expert report, therefore, did not consider that to be a case to change the scheduling controls on ibuprofen or aspirin at this time.
Actually, going back to that slide too, Catherine, I think it's quite interesting. We won't have to have another look at it, but, well, there it is. Gee, that's clever. We talk about 4 grams a day as being the most appropriate dose for paracetamol, but we're considering really 60 milligram per kilogram is the appropriate dose. Yeah. So if you've got a 45 kilo little old lady or little old man for that matter, then 4 grams a day is actually too much. You should be looking at 3 grams a day. So we're very focused often on children's doses for analgesics, but often we don't consider what's an appropriate dose for an older person as well. As I mentioned earlier, there's more changes mooted for paracetamol pack sizes in 2025. So for non-pharmacy outlets, so grocery, supermarkets, service stations, down the market store, wherever, a maximum of 16 500 milligram tablets instead of the now 20. Pharmacy self-select will be reduced from 100 to 50 tablets, and non-self-select will be 100 tablets. So, and again, there's, as you can see there on the bottom of that slide, some regulations regarding blister packing as being mandatory. There is a risk, though, of course, with all these changes to codeine and particularly paracetamol, that there could be some undermanagement of pain. And one of the risks, a significant risk of not treating acute pain appropriately is, of course, increased risk to transition to chronic pain, which is so much more difficult to manage. And of course, there's a negative impact on patients' well-being anyway. If they can't treat, or we can't help them treat their pain effectively, they're not happy campers, are they? Not really. So what happens? Well, particularly sleep is disrupted, difficulty falling asleep, drowsiness the following day. We know in community pharmacy, lots of people come in for sleep-related products. They want something to help them sleep. Do we always ask them about, are they getting to sleep easily? Do they wake up later? What do they think is causing their sleep disturbance? Often it's pain related. If we can treat their pain, then maybe we don't need to give them a sedative. Maybe they don't need a benzodiazepine from the doctor, for instance, if we can manage their pain effectively. So sleep disturbance is a particular problem. This study, over 400 people, about post-operative pain. I should declare that in our pharmacy we look after a small private hospital, and for almost everybody post-discharge they get paracetamol, an NSAID, and very often, most often, an opioid as well. But we're strict in talking to those patients on how long they should take their medication for, what dose it is, the frequency, the duration, and so on. So, but clearly, if the pain post-operatively is not treated effectively, and of course, not everyone discharged from hospital gets the superb attention that I give them on discharge, so they may not get the correct advice about all those things I mentioned. So, all of these things, delayed time in walking again. This is related to people with hip fracture. Walking ability, greater potential for problems associated with physiotherapy, and of course, staying longer in hospital. Another study related to health-related quality of life. Then when the acute pain was not managed properly, these are the problems that occur. Bodily pain, physical functioning, social functioning were compromised. This is a US study. And sleep, sexual function, ability to perform physical activities were substantially impaired. There's no truth to the rumour that the hip fracture in one of these studies was caused by inappropriate sexual function. Won't go there, not anymore anyway. Chronicity, therefore, is one of the major risk factors of inappropriate acute pain management. This study, another study in the US of over 5,000 patients, showed that if the pain was not managed effectively initially, that over 30% transition to chronic pain. And indeed, deviations from the guideline recommended processes of care were associated with much greater likelihood of transitioning to chronic pain. Catherine.
I think it's a really important point to note that we probably all have managed acute pain inappropriately because we may have thought it was not terribly serious at the time. So this is very, very pertinent for us, our families, but also patients in the community. So we've got some questions about, what can pharmacists do to optimise the analgesic space? Thinking through what John has rightly said, that acute pain can easily transition into chronic pain if we don't manage it effectively. And the impact of pain is not widely regarded by UN agencies as a big top NCD. It's related to every single thing that we have. So optimising use of pharmacy analgesics can help ensure that patients can achieve adequate pain control and avoid harmful behaviours. I think this also increases their confidence to be able to self-care. When they start to feel that they are having autonomous or empowered control over pain management, a lot of the other side effects or toxic effects or harmful effects are minimised. There's a quick refresher here around acute pain. It's defined really as being present for less than 3 months, and it usually has nociceptive components. Subacute pain is episodic and over about 3 months or more. You could have recurrence of individual acute pain times, but actually they can build up into constant acute pain. And common types of acute pain seen in the community pharmacy presented, again, you might be thinking they weren't presented early enough, so they're already established, include acute tension headaches, dental pain, acute soft tissue injury, musculoskeletal injury, osteoarthritis, flare-up, so maybe it's a chronic with an acute on top, lower back pain, sprains and strains, and period pain. Very often seen, perhaps not often drilled into to stop it being established. And a common pain assessment can help identify type and cause, as well as the context in which the pain is experienced. When acute pain is mild to moderate, you might see a patient presenting in the community pharmacy, given the availability of over-the-counter analgesics, and they might know one and ask for that specifically. So there's a real need to drill down into what are you experiencing with what you are being advised to take. And it's really important to go back to basics on this and think about the inflammatory response that pain is connected to. That we've got actually a prostaglandin cycle here, and we need to be impacting it at cause or at flare-up. They also potentiate pain perception, reducing the stimulation threshold of pain, and then causing increased sensitivity. So if you can get your analgesia in earlier, it will have a bigger impact all round. We can see here there are membrane phospholipids, there's arachidonic acid, cyclooxygenase, and we've got our prostaglandins. And all of these then have a potentiated effect that increase the impact of pain. And we all know that pain results in altered, or you hold yourself in a different way, which can result in other pain on top of it. It's very important for us to think about the tissue trauma, the irritation, the cause of the pain, as to whether it will be self-limiting, curing, or needs a triage around that as well. Over to you, Jean.
Thanks, Catherine. Well, I think a key component, a critical component really of pain management is to make sure that people, our patients, understand that we're not setting out to eliminate pain, which is almost impossible, but simply to facilitate return to normal functioning. So the management of pain, not the curing of pain, is what we're aiming to do. And we must, I guess, convince our patients that that's the aim, not just to relieve pain completely. So to do this, we need, I guess, to understand the patient's attitudes and beliefs about their condition, their treatment, what other treatment are they on, what are their expectations, because incorrect or unhelpful expectations are going to lead to harmful behaviours, maybe overdosing, maybe too frequent a dose of their pain reliever, or other attempts to eliminate the pain. So setting realistic expectations is a major kind of component of pain management. So how do we do this? Well, a number of ways. Patient education, I've kind of alluded to that in what I just said, but to empower self-care through improved health literacy. I mean, FIP has been talking about health literacy for a long while now. Maybe it's something we'll never fully achieve, but certainly that's something we must aim for. So educating people about the type of pain they have, the most appropriate pain relievers, and particularly non-pharmacological interventions. So physical interventions like maybe a hot pack or a cold pack when appropriate, massage, physiotherapy, exercise-based therapy, so keeping people moving, because we know for the vast majority of pain, we need to keep moving, keep mobile, keep active. TENS might be appropriate from time to time, and of course psychosocial interventions. Targeted reassurance, asking people when we give them what we believe is the appropriate advice, to come back and see us in a week or 2 weeks or whenever, to report back as to how they're going with the management therapies or strategies that we've introduced for them. Expectation management, I've mentioned that. Motivational interviewing and relaxation techniques. There are lots of information we can provide in terms of written or printed information we can give our patients, as well as the product and the verbal advice and information. Catherine posed the question, what can we do? And suggested some things. I'm going to mention some other things. We want to create an engaging, shame-free environment. We don't want to, blame our patients for the pain they're experiencing. We need to tailor our conversations and our recommendations to the specific patient, personalise our recommendations, and use, when appropriate, the teach-back technique that we know of. So get a response from our patients when we're providing them with the information and the product recommendation. How do you feel about this? Are you happy about taking the product as we've recommended? And what can you tell me about what I've just mentioned to you? That kind of teach-back. So we know that there are various levels of pain, mild, moderate, severe pain, and lots in between. And the non-pharmacological strategies are the foundation recommendations for all our pain conditions. Always we should be using non-pharmacological strategies. And there'll be different ones for different levels of pain perhaps. Then paracetamol with or an NSAID or an NSAID alone, depending on the condition, recognising that if the pain has an inflammatory component, and most acute pain does, then an anti-inflammatory, as in an NSAID, if not contraindicated, would be the first-line therapy. Then for more moderate pain, there could be, again, of course, non-pharmacological strategies. Firstly, maybe paracetamol and an NSAID, and then going up, perhaps a low-dose opioid, which in most countries now we cannot, or it's inappropriate for us to recommend. So if the pain is not being managed appropriately with our non-pharmacological strategies, the NSAID and the paracetamol, or maybe the NSAID alone in an appropriate dose, then we should be referring to a doctor for more appropriate therapy. And then, of course, strong pain, the non-pharmacological strategies, the NSAIDs, the paracetamol, and the opioid, as long as we specify with all of these things how long, the duration, the dose, the frequency. That information is vital. Catherine's already mentioned the chemical processes here with the prostaglandins and how the NSAIDs work to counter the prostaglandins there, either through the cyclooxygenase 1 pathway or the COX-2 pathway. And we know that there are various effects depending on whether the NSAIDs are COX-1 and COX-2 or a combination. And most of the non-prescription products we have in terms of NSAIDs are a combination of those. And we need to take account of the way they work and maybe the side effect profile as well. Paracetamol doesn't have a significant anti-inflammatory effect. It seems to work through a central kind of pathway, but often if the NSAID is not appropriate or contraindicated, paracetamol will have to be our analgesic of choice. And, as I'll mention a little bit later, sometimes the combination of paracetamol and an NSAID works really well in a synergistic way. So, paracetamol, what are the potential side effects or contraindications. Well, in terms of contraindications, only hypersensitivity to the specific ingredient happens with some people. Hepatotoxicity can occur following paracetamol overdose, and as I mentioned early on, taken in an appropriate non-prescription dose for an appropriate duration of time, paracetamol is quite safe. But in overdose, I mean, paracetamol is ubiquitous, isn't it? I mean, it's all over the place, not just in pharmacy, but non-pharmacy outlets and in various combinations, say cold and flu products and so on. So we need to be aware not just of what we might be recommending to someone if we're recommending paracetamol, but what other paracetamol-containing products they might be using as well. So overdose, problematic. NSAIDs, well, they're not free of side effects or contraindications either. We know they're listed there in terms of gastrointestinal irritation and other things like headache or dizziness, salt and fluid retention, hypertension, particularly relevant if we have an older, frail patient. Something that's really important, though, to know is that the risk of gastrointestinal adverse effects with NSAIDs is very much dose-related and also depends on the particular NSAID we might be recommending. For instance, ibuprofen is no more likely in non-prescription doses to cause gastrointestinal adverse effects than is paracetamol. Ibuprofen in non-prescription doses for the appropriate duration should be taken on an empty stomach, unless someone is particularly sensitive to that product or NSAIDs generally, on an empty stomach, because it works more quickly, the patient gets quicker pain relief. So I know in Australia, and I suspect in many other countries too, there's almost a default recommendation to patients when either they self-select or we recommend an ibuprofen product to them. We say, make sure you take this with food. We shouldn't take that. We should be saying, unless this affects you adversely, you should always take this on an empty stomach for quick, effective pain relief. Now that applies to some extent with diclofenac as well. Diclofenac has other potential adverse effects, but not gastrointestinal side effects, not in non-prescription doses. On the other hand, naproxen does. Naproxen should always be taken with food to minimise gastrointestinal upset. So ibuprofen, empty stomach for best pain relief, no more likely to upset the stomach than paracetamol in non-prescription doses. Back to you, Catherine.
I also think as well, John, it's worth just reminding ourselves that you can only control the messages you give in a pharmacy, that we should be educating patients and the public that they might buy something for a cough and a cold or for sleep or to help them through the night with a cough and a cold and associate the paracetamol they're getting in their pharmacy for pain and not think about them being a double dose there. So that's a really good opportunity for a bit of an intervention. It's important as well to note, not only with the advice John's just mentioned about when you should be taking the different types of NSAIDs, but also what you're taking them for. And some of the first-line recommendations we can be empowered to advise for common acute pain indications in the UK include lower back pain, which a lot of people suffer with, and interesting to note, this increased markedly during the pandemic as people were working more from home and not even having commutes or normal daily activities. Then in this case, you would be advising ibuprofen, 400 milligrams, 3 times a day, and where possible to be taking that on an empty stomach should the person be able to. And at the lowest dose for the shortest period of time, not to keep taking it as a long-term treatment. Not to offer paracetamol alone is a really important point here. Then you may have to advise for a tension-type headache. Some of you may be having them due to your jet lag. Some of you may be having them due to different conversations that you're having. That you would advise aspirin, 300 milligrams, 3 times a day. a paracetamol or an NSAID, taking into account the patient's preference and their comorbidities. So again, that thing in a pharmacy that you can do that perhaps someone buying them themselves is you can ask around the issues. You can ask, do you have other conditions? And then you can establish whether somebody can take an NSAID or not. Then we've got migraine, and we've got to think about that being medically diagnosed, not just self-diagnosed because it's a bad headache. That's a really common thing that you see, people thinking, I've got a very bad headache, I'm going to call it a migraine. And before over-the-counter medication can be recommended because there may be something being prescribed for this. There's a combination here of sumatriptan, no more than 2 50-milligram tablets in 24 hours. So you'll see we need to be really careful what we add in on top of that. That dose regime is quite clear and quite limited. NSAID or triptan and paracetamol. And if the patient prefers one drug only, lots of people would prefer to only be taking one drug, then consider monotherapy with oral triptans or an NSAID or paracetamol alone. Opioids should definitely not be used for the acute treatment of migraine. And I think, as John said, we've taken opioids pretty much off the table because of the limitations around them, but it's worth us explaining why we wouldn't be offering them even if we could. My point to that is that people may have medicines at home that we don't know about. So we shouldn't be assuming that they're going to be taking what we give them or we advise them. They may be self-medicating with other things as well. It's gone ahead. There.
Going back a bit. Yeah. Now, we mentioned earlier, I think I mentioned, and Catherine did a minute ago as well, about not taking paracetamol alone for various inflammatory conditions. And I did say early on too that sometimes the combination of paracetamol with an NSAID works in a synergistic way. And there's some good studies now. This one, originally done on dental pain, showed that the combination of ibuprofen 200 milligram and paracetamol 500 milligram was not just effective, but even more effective than, this is a single dose of 200 milligram ibuprofen, 500 milligram paracetamol, more effective than 2 of the 200 milligram ibuprofen, or 2 of the 500 milligram paracetamol, significantly more so than the 1 gram of paracetamol. So I know there are several formulations around of this combination, but this is the one on which the studies have been done. It is possible to take 2 of those tablets, but interestingly, just one 200 milligram, 500 milligram combination is shown to be so effective in the relief of pain. As I mentioned, it's originally done on dental pain, but I think we can extrapolate that to other acute pain conditions. And indeed, this study in another form has shown that that combination I mentioned, 200, 500, achieves the 50% maximum pain relief much sooner than any of the other products, most of which are available as non-prescription products in some countries, not all in every country. And the reason that the 200-500 combination, I think, is so beneficial, not just for our patient, but for us as well to recommend, is that we're using the lowest effective dose for the shortest possible time. So it's good quality use of medicines. So I think that's always worthwhile remembering that particular combination product for acute pain management. So this graph just shows the tolerability of the various medications we've listed there, indicating that in effect the tolerability of all of those medications, including are well accepted and similar to the placebo adverse effects. So Opportunities for community pharmacists. Well, we've mentioned these, but it's worthwhile reiterating that we need to reinforce the dosage instructions, dose, frequency, duration. Explain how to assess the medicine's efficacy, that is, for our patient, before they take another dose. No, don't just double up because you think it might be a good idea. And always emphasise the importance of non-pharmacological interventions. We know that ensuring effective acute pain relief can help reduce the risk of chronicity and, of course, harm from medication overdose. What can we do? Well, this is a kind of a toolkit in a graphic kind of way. We can use reactive treatments, can't we? Hopefully we don't need to use analgesic or anti-inflammatory or steroid injections too often, not in the community pharmacy setting anyway. Oral pain relief quite frequently, heat or cold packs. In terms of proactive treatments, supplements may be of use, but make sure if we're going to recommend supplements, we recommend supplements that are evidence-based. I know that in Australia and many other countries, glucosamine is one of the most frequently recommended and sought after, purchased, so-called complementary medicines, and yet the evidence is very poor. I know the guidelines in both in the UK and Australia, glucosamine is not recommended, for instance, for the treatment of or management of osteoarthritis. It's thought to be of no value whatsoever. There may be some benefit in some other herbal medications, for instance, like curcumin, turmeric, boswellia, but the evidence is still coming. The jury's out, so to speak. So we're looking forward to seeing whether there is some evidence about those, but not with glucosamine or glucosamine and chondroitin. Physiotherapy, of course, can be helpful, and physical exercise, movement, keeping people active, absolutely essential. So one of the areas I thought we should mention is what I believe is the perhaps the underuse of the non-self-select pharmacy analgesic range. Very often people come into the pharmacy, they self-select an analgesic, whether it's paracetamol or an NSAID, and they take it to the checkout area and they pay for it and they go away, maybe happily. But do we ask those people how you manage your pain with this product? Are you getting the most appropriate relief? What kind of pain do you have? Wherever possible, open-ended questions. How often do you need to use it? What other medicines are you taking? So just because someone comes into the pharmacy and self-selects doesn't mean to say that's the most appropriate product for them. So wherever possible, we pharmacists should be talking with those patients seeking pain relief and recommending an appropriate product for them, which may be, very often is, in the non-self-select area. What in Australia we call Schedule 3, which is behind the counter, requires pharmacist intervention, pharmacist advice, and pharmacist communication with the patient. So you can see some of the study results there where more than 80% of people agreed that the main benefit of non-self-select section is better service. Analgesics were considered the most clinically useful non-self-select category, and in terms of a business point of view, pharmacists, around half, believe that non-self-select section has higher margins, and therefore it's not only good for the patients, it's good for us from that business point of view as well. So we could give the modified release formulations for longer duration of action, maybe higher dose formulations for moderate to more severe pain, and larger pack sizes if appropriate. They're all in that non-self-select area. How can we manage it better? Well, we need to train our staff better. We need to train our non-pharmacist staff to refer to us if they believe that the patient could be better treated by a pharmacist intervention. Sometimes the consumers forget that the non-self-selection is available. That's probably our fault. We haven't made sure they know that there is a section in the pharmacy between self-select and prescription that we may be able to provide better, more appropriate and more effective management for them. Training, I mentioned. Improving workflows, maybe that's important as well, to ensure that self-select area is appropriately designed and visible. Now, Catherine, you can tell us all about this case study.
Before we do, was there any particular question? I think the case study really draws out a lot of issues, and that's probably going to illustrate maybe some questions that are in the audience. But before we start, maybe it's just worth seeing if there's any issues for clarification.
You can't leave the room unless somebody asks questions. You know that, don't you? The doors are locked.
That's it. You can get out any time you like, but you can never leave.
Question down here.
Trevor Gore from the UK. You both mentioned early on getting fast pain relief is important. You mentioned the sustained release products, but there's a lot coming through of now faster acting, whether they're using sodium salts or Actisorbs or whatever. What's your view on those, on their benefits?
Okay. Shall I take this first, Catherine? There are various salts of the original active ingredient that are considered to be faster acting. Essentially, they're better absorbed, more quickly absorbed, and the studies would show that they reach peak concentration more quickly, and there's a greater area under the curve, if you like, of pain relief. So generally, they're a little bit more expensive, but if someone has an acute pain, for instance, could be a headache, tension headache perhaps, and they want quick pain relief, I think they're very well worthwhile recommending. There's those so-called fast-acting variations and a number of products. Yeah, I think they're good products to recommend. Depends on if someone's maybe taking a pain reliever maybe at 6 or 8 hourly intervals over a few days, then probably that's not as significant. But for quick, immediate pain relief, or as quick as possible, won't be immediate, recommend those faster acting products.
Yeah, I think fast acting is the aim, isn't it? And then if you have recurrences, maybe you would start to mix the different formulations to get the best pain relief, but fast acting is first. Okay, let's move on to our case study, and you can all be considering...
There's another question.
Sorry, apologies. I can't see, actually.
No.
It's really interesting. You can't see from here. Yeah.
Okay, my name is Chioma.
Over here. Sorry.
Speaking. Chioma from Nigeria. You mentioned in your presentation, we've talked about the disadvantages of long-term use of the NSAIDs. Now, in management of a chronic illness like osteoarthritis, you also mentioned that there has not been any proven beneficial benefits of using the supplements. So I want to ask, how would you then advise management of pain in osteoarthritis, being a chronic condition? So what would be your advice for that?
We're talking chiefly about acute pain here. Osteoarthritis is a chronic pain condition, but certainly from time to time people get flare-ups of osteoarthritis. And for flare-ups, the NSAIDs are certainly the first choice medications because we're looking at treating with non-prescription products for a short period of time, maybe 3 or 4 days, and that should manage a flare-up fairly well. In terms of the long pain management of osteoarthritis, firstly, mobility is important. So the non-pharmacological strategies that we've mentioned, keeping active, maybe physiotherapy, ice packs, heat packs, depending on the particular patient and when they and how they experience their pain. NSAIDs may still be used long-term for particular patients, but on prescription. So for non-prescription therapy, we're looking at a few days only. But NSAIDs may be useful over a long period of time for people who have contraindications to NSAIDs or to oral NSAIDs. Often the topical NSAIDs will be useful for long-term or even flare-ups in combination, say, with paracetamol. So if someone can't take an oral NSAID, paracetamol with perhaps a topical NSAID could be useful. But that's a whole new talk about chronic pain management.
Yeah.
For osteoarthritis flare-ups, NSAIDs first-line therapy, both from guidelines in the UK and in Australia.
And that comes to the point we were mentioning earlier about over time, if you have recurrences, you can build up a bit of an arsenal of different types of formulations and different medicines for what you're experiencing. We'll take one more and then we'll go on to the case study.
Hi, it's Tammy from South Africa. Just on the upscheduling of codeine and a question there, has there been any impact analysis of that decision since 2018 or since its implementation? What's happened to those patients? Because certainly they needed the codeine. Have we seen it? Has your market seen a diversion to increase in the scripts, or these patients have resorted to other type of chemical entities for dependence? And you spoke about margins, so has it done anything to the margins in the pharmacy? Thanks.
In the Australian scene, we thought there would be an enormous impact. Certainly there was an impact on the sales of products with codeine because we can no longer sell them without prescription. But in terms of patient benefit, I don't think there has been an adverse impact at all. Now, certainly patients need to talk with their pharmacist and their doctor about the most appropriate pain management strategies, but non-prescription doses of codeine were never really all that effective. Now, people could take higher and higher doses, but when they were doing that, they were also taking much higher doses, higher than appropriate, of the NSAID that was in combination with the codeine or the paracetamol that was in combination with the codeine. So from an evidence-based point of view, the fact that we've lost codeine as a non-prescription product has not had an adverse effect on our patients' health and welfare and outcomes. But it needs a better, a longer, a more appropriate conversation with the pharmacist, and if the non-prescription doses are then not effective of what we have, which is maybe modified release paracetamol or modified release ibuprofen or a combination paracetamol and ibuprofen, then it's referral to the doctor.
I think the risk-benefit ratio shows that perhaps it was the misuse that led it to be withdrawn, which also means there's less of a daily impact, if that makes sense. So let's go on then, John. Thank you so much for that. Let's meet Vanessa. She's 35. She's a store clerk and she's female. She's got pain and stiffness in her lower back and it's been bothering her for a few days. And then again, that's interesting, the few days. She's been taking paracetamol every 4 hours, but it's been difficult to keep track of when she has taken the last dose when she's working. So we haven't got an idea there about how much she is taking, really. When she approaches the pharmacy assistant, her basket has a fast-acting paracetamol and a diclofenac spray. And she asks, is there a stronger paracetamol I can get from the pharmacy? So the assistant refers Vanessa to you as the pharmacist, as she's already taking a medicine. Very good, following of the protocol there. And then the pharmacotherapy recommendation for Vanessa is a comprehensive assessment that then she really starts to disclose that she's experiencing moderate level of non-specific low back pain. That's affecting her ability to work. So she needs some help with this because she needs to be comfortable while she's working. Lower back pain is associated with inflammation of muscle layers. And again, as John was saying, if you can use some non-therapeutic inputs, maybe like a hot water bottle, that can relax you and that can offer an awful lot of relief. Paracetamol may be considered if they are contraindicated to or cannot tolerate NSAIDs, and we know that because John has told us about the impact of that. What we are coming to around all of this is multimodal analgesia. So you might combine it and you might use other non-therapeutic techniques. So that's the pharmacotherapy recommendation here. And then, given Vanessa's difficulty with keeping track of her doses, every 4 hours is one way of thinking about it, but as John said, you can soon accumulate your paracetamol. She's finding this difficult during the day, and no contraindications or precautions have been established. So you would recommend 12-hourly modified release ibuprofen tablets. And this would make sure she can keep track. She's got a constant pain relief going on. You can explain to Vanessa that the paracetamol is available in a higher dose, but there may be more appropriate pain relief and options, especially with the symptoms she's described for her lower back pain. It's inflammatory, so an NSAID would work best. You'd want to educate her on the likely causes, and you'd want to talk about the other ways in which she could treat herself to relax and get more mobility. It's very important, as we've been saying throughout, that we would ensure the person in front of us, Vanessa in this instance, is cognizant of how ibuprofen works, the difference between that and paracetamol, and how a modified release formulation is long-acting, and that she will get sustained pain relief as a result. You'd also want to keep her posted about the product's directions. Very important, because remember, she's used to every 4 hours, and we don't want her to take a modified release every 4 hours. So that's really important if someone is a little confused. It's important when you would be talking to Vanessa that you would address misconceptions and coping strategies that may cause the problem to worsen. And I would say use of heat and relaxation and trying to not overcompensate for lower back pain is very important. Staying active, a hot bath, for example. The summary then here is when the patient describes it to you, we don't necessarily have to go back to the protocol in our own minds. We need to explain to the patient why it's important. We've either changed the release function, the drug itself, why the other drug isn't working. Very important, really, to have that conversation so they feel empowered with their short-term pain relief. The harms associated with inappropriate use of analgesics have led to regulation changes, and that changes the way in which we can offer therapeutic management. But we should also remember that inadequate management of acute pain will lead to more problems down the line. So it's important to nip it in the bud, I suppose, is the phrase. And pharmacists are ideally placed to ensure that we appropriately manage acute pain by optimising what we have in our arsenal in line with a stepwise multidisciplinary approach. We should also prioritise non-pharmacological uses as well. Oral NSAIDs are preferred with inflammatory components. Multimodal analgesia gives you a layered effect, and you get a multiplicity of analgesia. The non-self-select selection of pharmacy broadens the analgesic options, and we need to empower patients that it's not an either-or, it's an and. Go and self-select, come and have a chat. It's really important that we use our role and we talk about this in terms of self-care, because the component medicines have is within the self-care arena. And also, as John rightly said, realistic outcomes for treatment. I think we are done with our slides. And I'm just trying to find my mouse. Yeah, there we go. We can take some questions if you are interested. That case study is a really good one. It's somebody who's young, relatively young, who perhaps doesn't realise that the pain will be short-term, perhaps doesn't have other morbidities. So it's a very good example of a pharmacy intervention that will achieve good outcomes, potentially.
Another question? Anyone? Yes?
Hi, Adrian from the UK. You mentioned health literacy. Have you perhaps got one example of what could be done in the pharmacy to improve that in relation to acute pain management?
I've got an example, Adrian, that I think illustrates the problems with how we think of health literacy. We kind of think people are health literate or not. But actually, perhaps as patients age, their literacy may be diminished because of other conditions. So it's very important for us to establish what the patient knows and how they would be managing their therapy themselves, and to establish if there's any confusion, how you can step in and help clarify it. I think this is something that FIP is thinking about, actually, Adrian, in collaboration, that it's not a binary thing, but people can change their health literacy over lifespan, and we need to be there to pick it up. And also whether pain is causing other things or pain is being caused by other things is a really good a point to note as well.
Yeah, I think that's absolutely right. I mean, as I said a little while ago, it's really important to have a chat, a communication, if you like. We could call it a consultation, if you like. And it might only take a few seconds or a minute or two at most, but we need to understand the patient's understanding and expectations of their condition. In this case, we're talking about pain management. It could be almost any condition at all. To get an understanding of what they think about their condition, what they're using and why they're using it. And as Catherine said, health literacy is such a personal thing. We assume very often that people know what we're talking about, and often we're talking in jargon, or we're giving them a quick response. We're not asking enough questions before we make our recommendation. So an assessment of the individual's health literacy is really an important thing to do.
I think as well, we know that certain things can happen inadvertently, but we don't always address that up front. So we tend to give information as it's asked for, as opposed to giving the information up front. And that's really important with patients using medicines they're buying somewhere else and not thinking that that may have the same medicine in the one that you're offering and advising. It's very interesting. You can make these assumptions, and that could lead to harm or lead to inappropriate acute pain management.
Well, I think we've probably come to the end of our available time. Another question? Oh, yeah, we've got it. Yep.
Thanks for the opportunity. Zaid here from New Zealand. I've got two questions. The first one is on the supplementary side for pain management. Has there been any studies? I know from practice people get benefit from fish oil, high doses, and also magnesium in terms of pain management. Do those two things have a role in acute pain management or just chronic? And the second question, would you consider any recommendation for giving other medication to help with adverse effects of recurrent acute pain users in terms of NSAIDs, like for example, omeprazole? What's your thought on that, please? Thanks.
In terms of fish oil and magnesium, I don't think there's any role at all in acute pain management, none at all. The evidence about chronic pain management is not all that good either, to be honest. Fish oil in high doses, quite high doses, may have some cardiovascular benefit, but I think the evidence about chronic arthritis is not all that strong either. So I think fish oil is still one of the most commonly requested complementary medicines, as is glucosamine, as I mentioned, but the evidence is not all that great. And certainly with magnesium, it's even less great if it could be. So the second question was about... Oh, yeah. Look, it's important to have a conversation with your patient about what they're taking and how they're taking it. If we believe people are taking too much of a medication, I think that's what the question's about, isn't it? Then if we can manage that, great. If we can't, we need to refer them to the doctor. So recurrent medication with whatever it happens to be inappropriately is something that we need to address and talk to our patients as to what the medication does, how often it should be used. I mean, if someone's getting maybe a migraine, then an NSAID from time to time, like it could be a recurrent acute pain, is not unreasonable. That's fine, provided they're not exceeding an appropriate dose. So it's a matter of a conversation with your patient, understanding how often they're taking it and whether there's a potential problem associated with that. And of course, we know there are potential problems with any medication, whether it's aspirin or paracetamol, any of the NSAIDs. So we need to manage the benefits against the risks, and that involves talking with our patients. Catherine?
I think you've said it all there, John.
Okay.
And I think it's really about weaving in everything that we've just presented and thinking about the patient in front of you. If it's recurring and recurring and recurring, possibly a referral will be needed. But also you've got the layering options as well for different types of pain. But I think there's a nice stepwise approach in the presentation that we've just given you.
Well, thank you so much for coming, and thank you for your involvement, your conversations, your questions. I'm sure, I mean, I'll be around for a while. Catherine's got 1,001 other things to do, so I can't guarantee she'll be able to answer more questions on this subject unless you contact her back in The Hague somewhere. That's possible. But in any event, I'll be around for a little while. For the rest of the week, if there's any more questions, I can help you with. And thank you for FIP and for Reckitt to enabling us to talk about a subject that's so close to my heart. Well, actually, it's closer to my lower back. But in any event, thank you all. Enjoy the rest of your day.